has been always lifetime partner in supporting education in the whole northeast of the country. Thank you very much indeed. I'm going to move now to the trainee presentations. I'll leave this to Kath, Grant, and Liam O'Hare just to conduct this. This is the last session. Thank you.
Thanks, Khaled. Kat's gone home with a migraine, so Kizar's kindly stepped in as my co-chair for the last session. So we've got three presentations by three of our trainees. The first one is by Khaled Bhatti, if he's there.
Yes. Thank you very much.
So you want to go ahead, you're able to share from your computer and take us through your presentation. Thanks.
Good evening, everybody. So can please confirm that you can see my slides?
Yeah, that looks good. Yeah.
Okay. Thank you very much. I'm Khaled Bhatti. I'm currently working at Sunderland Royal Hospital, and today's presentation is Triaging Surgical Patients during second peak of SARS-CoVI-2. Can ACCI help? So ACCI is Age-Adjusted Charlson Comorbidity Index, and it was developed in 1990s as a predictor of one-year mortality based on the comorbidities. At that time, they included 19 medical conditions, which were further later on modified up to 16 medical conditions, and it can predict up to 10 years of mortality based on these comorbidities. The maximum score is 12 and the minimum score is 0, and it's an online calculator which is easily available and it's very easy to use and it's free of cost. So they have used the summative score, and the summative score has advantages because you don't need to count the number of medical conditions. Rather, you should use the weightage. And we know this from the fact that every comorbidity is not the same, as hypertension is not equivalent to diabetes mellitus, or uncomplicated diabetes mellitus is not equivalent to the complicated diabetes mellitus. And the next thing is that it actually also adjusts for the age, so you don't need to calculate age as a risk factor independently. So the background is that we are suffering from COVID-19 for the last 1 year, and the waiting list has gone to up to 51,000 patients are waiting. This is the data from 2 months ago. So of course this has gone even worse, and among them there is 36,000 cancers, which we were discussing previously during the session as well. So it was predicted that it would take about 20, if you use £2 million and do a 20% extra activity, then still it will require about a year to complete the backlog. And I think the situation has become much worse now, because on daily basis we are getting about 25 to 30,000 patients of COVID. Is there any way to deal with it? I think there are a few policies which are under consideration, and one of them is that we should triage the patient based on urgency. So the P1 category is emergency procedures which need to be done then and there within less than 72 hours time. But the P2 category is the cancer work, and P3 and P4 is the elective work. Now there is an attempt that we can actually decrease the list by calling the patient, asking them if they are concerned about COVID-19, and then at that time we can put them we can take them off from the waiting list. I don't know how much it would sort out our problem, because there would not be a lot of people who are concerned about COVID and don't want a surgery. So the limitation of the current practices are that the cancer work is 10%, 90% of the work is actually a benign work, which is P3 and P4 categories. So it would mean there are 460,000 patients in UK which are waiting for the surgery. Now there would be a way, how to offload this 90%. One way is that just wait so that they become P1 category, and then we operate on them, which is not very much sensible. And then comes that treat everyone. We can't, because there's stress on the resources, and there is also other than resources, there is a risk of cross infection from patient to patient, patient to surgeon, and from surgeon to patients. So what should we do? I think we need an alternative prioritization based on the comorbidities. What we are suggesting is that the patient with no comorbidities, they need elective surgery, they should be prioritized first. Why? Because they are more in number, first of all. They have a less chances of infection, and they have a less chances of having poor outcomes. Moreover, they don't require a prolonged hospital stay, which means there will be less stress on the resources. So we hypothesize that postoperative infection rate in surgical patient with low ACCI score, which is like 0, is significantly lower than those with the higher scores. So we defined hospital-acquired infection rate developing between 7 and 30 days of hospital admission after any kind of surgery, and we did a prospective observational study over a period of 8 weeks starting in March. So included all the consecutive patients, and our outcome included the post-operative infection rate, morbidity, and 30-day mortality. And we tried to figure out that what are the risk factors for these post-operative infections. So results-wise, we had a 550 procedures on 418 patients. COVID test at that time was very, very selective. We were doing on symptomatic patients only. So we had 167 patients who underwent the test. 52 cases were positive. 15 were the developed infection in the perioperative period. Post-operative infection was in 37 patients. During that time, 131 patients were confirmed negative. So we also came to know that actually this is a prolonged hospital stay, which puts the patient at risk of developing infections. So 11 days of hospital admission would result in 12% of the patient to develop infection. The male and female was almost equal. Mean age for developing infection was 77. And if we did a univariate analysis, and we can figure out from here that the age was matching with the nationally and internationally reported data. So mean age was 77, and if we go by the groups, then more than 65 years of age group, they had more than 90% chance of getting infection. Then ACCI, if we did a median mean, so mean score of 6 and median score of 6, that they were at increased risk of developing infection. We further divided into different groups based on score 0, and 1 to 3, and more than 4. And the other factors, which were like specialty, vascular surgery, spinal anesthesia, the trauma, and emergency surgery. So these all are the factors which lead to increased risk of infection. That was a univariate analysis. We went to the multivariate analysis, and we found interestingly that ACCI groups, they are the second most important factor in developing infection other than orthopedic and vascular procedures. But again, these procedures could be because they have a lot of comorbidities. So if we go for the diagnostic accuracy or as a stratification tool, then the ACCI score of 0 has a 98% negative predictive value, which means that these are the patients who will only 1.3% of them, 37% of them will develop infection, compared to 4 or more. So if you keep on increasing the score from 4 to 11, the positivity becomes up to 100%. So 1/3 of these patients who have scored 4 or more, they will develop infection. Now, as I mentioned, the vascular procedure and orthopedic procedure were one of the covariables. So we did an area under the curve analysis, and the ACCI score has the area under the curve of 0.8. If we compare with the age alone is 0.75, and we use operative severity score is 0.67. And this is very clear that if this is the reference line, and if we use a severity scoring system, then the ACCI is on the top as compared to age alone or operative severity score. So we suggest that ACCI can predict the post-operative infection and should be used in triaging non-urgent patients. Patients with low scores should be prioritized first. And the suggested pathway is that if the patient requires emergency or urgent surgery, then you have to calculate the risk based on morbidity and mortality and morbidities like P-POSSUM score. But if the patients are elective, then use ACCI, and if the score is 0, offer them a surgery. If the score is between 1 and 3, then you need to really balance between the risks and benefits. And if the score is more, do not do elective surgery on such patients. How it will benefit there are more chances to decrease the waiting list because there are more number on the list of with the benign conditions and with low ACCI, because they are fitter patients. There will be less chances of infection postoperatively, less chances of poor outcomes, less chances of prolonged hospital stay, and less stress on the resources. I would like to acknowledge my team, and thank you very much. Any questions, please? Hello?
Sorry, I think you froze a bit there, just at the very last bit.
Which slide?
Khalid?
Hello.
Can you hear us?
I can hear you, yeah?
You can do. Sorry, we've lost your sound just for the half of the very last slide, but we read what it said, so I think that's fine.
Right.
Was that your last slide, or were you?
This is my last slide, which means that what are the benefits of this approach? Yeah. So there are more chances to decrease the waiting list, less chances of infection, less chances of poor outcomes, less chances for the prolonged hospital stay, and less stress on the resources.
Okay, thank you. That's
thank you.
Great.
Thank you.
So, a couple of questions that occurred to me. The first one was, what's your thoughts about why being comorbid, which is really what the Charleston Index is bringing out, why should that give you a higher chance of infection? What was your, rather than higher chance of succumbing to the infection, but higher chance of getting infected per se?
I think this is a dip in the immunity, because the patients who are having comorbidities like diabetes mellitus or chronic renal failure, or any patients who have respiratory problems. So these are the patients who are at greater risk of developing infection. And we have come to know recently that the infectivity of the COVID virus is not actually 100%. So not everyone exposed to virus gets infection. Infectivity is around 16 to 20%. So I think these are the people who are in our practice during the 3 months time, everyone was exposed to the equal standard precautions, and only 12% or 16% of them developed infection. The rest of them, they didn't develop infection.
And it wasn't purely a factor of how long they'd spent in the hospital?
It was, because the 12 days duration...
Because obviously elder patients will spend longer in the hospital,
yeah.
won't they, if they're more comorbid?
Yeah.
So do you suggest that based on this index, these patients can get away without 14 days isolation or a clean pathway? They can come in a different ward?
I think if we are using the same standard precautions as we were using during the previous peak, if we use the same standard precautions, then we can get away with the patients who have a less risk of developing infection, and secondly, they have a less risk of developing complications if they develop infection. Second thing is that the benign conditions, people from the requiring elective surgery, they will not require a prolonged admission in the hospital. This is another way of decreasing the infection rate.
My other thoughts were that you're using it as a way to pick out the older patients to delay their elective surgery. But the flip side of that is that older patients presenting it as an emergency with whatever condition they're waiting for their elective surgery for might do worse. So do you have any thoughts or comments on that balance of, risk benefits of getting on with the hernia repair or getting on with whatever the surgery is?
Yeah, so it would be similar once we do not offer a inguinal hernia surgery patient who has a greater risk of developing complication from a GA. So we don't, although we know that these are the patient who comes in emergency, then they will be at increased risk of morbidity and mortality. So same applies here, because if you try to operate them electively, if they develop infection, that they are increased risk of infection and dying out of it. So the point would be the same. As we are refusing surgeries to the patient for elective inguinal hernia, if they are not fit for surgery, there is an added risk that the COVID infection develops and then they go into the complications.
Sure. Okay. Thank you.
Thank you very much.
Thanks very much. So I think the second presentation is Jayarashini, Jayadison. Is that right? Are you there?
Hello.
Apologies for my pronunciation.
That's okay.
I'm sure it was terrible. Are you able to share your screen with us?
Yeah. Are you able to see what I'm seeing?
Yes, that's fine. Yeah, that's great. Thanks, Jay.
So hello, I'm Jayarashini. I'm one of the CT2s from Northumbria Hospitals. And so today I'll be talking to you about a project on patients' outcomes following laparoscopic versus open approach in emergency.